and this is our national briefing webinar entitled Oral Health in Primary Care, a Framework for Action. We're thrilled to have so many of you joining us this afternoon. As you know, we're going to be featuring the new oral health framework that was developed by Qualis Health in partnership with the National Interprofessional Initiative on Oral Health. And they received generous support from the DentaQuest Foundation, the Reach Healthcare Foundation, and the Washington Dental Service Foundation. We are a proud endorser of this white paper and the framework within it, and I was honored to serve on the technical committee that reviewed the paper. So congratulations to everyone involved in this very significant piece of work, and we are thrilled to be able to endorse it today. Before we introduce our speakers, I've got just a few housekeeping items. First of all, as many of you know, we have our annual fall conference in November, and the early bird registration ends about a week from today. That conference is investing in primary care, patients, and payment, and we'll be discussing those issues November 11th through the 13th. We are also going to be having our second annual Barbara Starfield Awards dinner that evening, and we're going to be celebrating the significant contributions of three leaders that many of you know and love. Dr. Calvin Sia, who is the founder of the concept for patient-centered medical homes from Hawaii. Dr. Christine Sinsky, who's done a tremendous amount of work on the joy of practice, and she works at the Medical Associates Clinic in Iowa. And then Melinda Abrams and the Commonwealth Fund. Melinda is well known to many of us. She has been working at the Commonwealth on behalf of primary care for some time, and I have no doubt through the various organizations that have funded this work with Qualis, we can all trace our link back to Melinda and the support she's provided to all of us. So please do join us. It's going to be the primary care party of the year. I'm going to now switch to the webinar and just remind all of you that we've got webinar software that allows you to ask questions or to offer comments. And to do that, you need to submit your questions in writing using the drop-down question box on your screen. About the last 15 minutes of today's conversation, we're going to open it up for Q&A, and Amy Gibson, our Chief Operating Officer, will facilitate those questions. And as a reminder, we do have these slides and the recorded presentation. It will be posted to our website within the next 24 hours. So without further ado, it is my great pleasure to introduce our guest speakers today, Catherine Phillips and Jeff Hummel from Qualis. I'm going to only just highlight a few key points from each of their bios, and I would point out that their beloved boss, Dr. Jonathan Sugarman, is on the line listening. So Jonathan, we're all going to be on our best behavior for you today. But of course, they are both at Qualis, which is a fantastic, Qualis Health, a fantastic organization based in Seattle, but doing national work. One of their many talents is focused on practice transformation, and Catherine has long been involved in that effort since 2008. In fact, she's been serving as the director of their safety net medical home care redesign, helping 65 primary care safety net practices adopt a PCMH model of care. And we've worked with her a great deal, had her present at many of our conferences, and she is a rock star. Dr. Jeff Hummel is the medical director of informatics at Qualis. And although he started his medical career as a solo rural physician and did that for several years, he then came to the big city after he spent some time working in ERs in Southeast Alaska. And he spent 13 years at Group Health, one of the premier health plans that has focused on medical homes and demonstrated very impressive outcomes. He then left for the University of Washington to focus on neighborhood clinic systems and EHRs, and is a pioneer in that space. And he's now been at Qualys for the last 6 years, helping them with their DOQ IT project, which is CMS' first effort to use quality improvement organizations to help primary care providers install EHRs. So with that, I thank them both for being here today. They're going to tell us about this framework, and then, as I mentioned, the last 15 minutes we'll open it up for Q&A. Thanks for your fantastic document, the framework itself, and thank you for being part of the PCPCC family.
Thank you, Marcy, for that warm welcome, and welcome to everyone on the phone line today. This is a primary care webinar series, so why are we talking about oral health? Dr. Hummel and I hope to make the case to you today that oral health should be a priority for primary care, and that addressing patients' oral health needs is really a critical component of achieving the medical home's promise of comprehensive whole person care. What's the issue? We have a prevention gap. Right? Oral disease is a largely preventable disease, yet nationwide, among all age groups, we have an unacceptably high rate of oral disease. Dental caries is the most common chronic disease among children, more common than asthma. 20% of adults have destructive periodontal disease, and by age 65, 25%, that's 1/4 of seniors, have lost all of their natural teeth. The costs and consequences are significant, particularly for vulnerable populations. And new research is demonstrating links between oral disease and diabetes, poor pregnancy outcomes, and other health problems. Whether you care about productivity, about employment opportunities, or academic performance, we also know that poor oral health compromises more than health. It impacts patients' quality of life. Insurance and other access barriers limit families' ability to get the prevention and treatment they need, and in fact, in most communities, dental care remains the most common unmet health need. The high burden of disease coupled with these access challenges results in wasteful healthcare spending for private and for public payers. In 2020, for example, Americans made over 2 million visits to the emergency department for non-traumatic oral concerns. Patients leave with antibiotics, with painkillers, but that's incomplete care delivered in the wrong setting. Expanding access to affordable dental care is an important goal in its own right, but that alone is unlikely to solve our current problem. The need is simply too great. We need an upstream solution, a way to intervene earlier in the course of disease. So what's our proposal? To expand the oral disease prevention workforce by engaging primary care teams in oral health, and to begin including preventive oral health care as a reliable component of routine medical care. In 2014, with the support from the National Interprofessional Initiative on Oral Health and a group of oral health funders and thought leaders, we launched a new effort to prepare primary care teams to deliver preventive oral health care and to improve referrals to dentistry. We began by reviewing the experience of recent efforts to integrate behavioral health services, which, like oral health, were siloed for many years. We also convened a technical expert panel to guide us. This included primary care and dental care providers, leaders from medical, dental, and nursing associations, payers and policymakers, patient and family engagement experts, and public and oral health advocates as well. And we asked this group a question. What will it take to change the standard of care? To make interactions like you see here on the left, a provider looking into a patient's mouth, just as common as in those in the picture featured on the right, a provider listening to a patient's heart. And they gave us 3 answers. First, a clear definition of what can be done in the primary care setting to protect and promote oral health. Second, a streamlined process for fitting oral health activities into what we know is already an absolutely jam-packed primary care workflow. And third, a practical model for a close working relationship between medicine and dentistry, health professions which have been separated for too long. So to address these 3 needs, we developed the Oral Health Delivery Framework, a conceptual model for how to address oral health in the primary care setting. It includes 5 actions primary care teams can take, and actions that are within the scope of practice for primary care providers and their teams. Dr. Hummel is going to walk us through this framework: ask, look, decide, act, and document in more detail. Jeff.
Thank you, Catherine, and thank you, Marcy. So the oral health delivery framework, as Catherine says, is a way to address the what we were told needs to happen in primary care for oral health to become part of the primary care practice. The framework itself is built around the way that primary care teams and particularly providers have been trained to work in their professional lives. So just as providers document their notes with a subjective or a section on what the patient told them and then what they've documented by examining the patient and making decisions and acting on them, the oral health delivery framework fits into that. However, what's important is that we've looked for ways for sharing that care across the entire team, because points out there really is more work in oral health and in chronic disease than any individual provider can do. For oral health, asking is really about asking about risk factors, things like oral hygiene practice and diet, or symptoms of salivary dysfunction that may be related to medications, and then teaching the primary care teams to look in the mouth for signs of oral disease, in which we're focusing primarily on caries and periodontal disease. The decisions then are ways of intervening for what the care team finds. And so there are things in primary care that can be done. The main decision that's made by the primary care provider is, does this patient have excessive risk factors for oral disease that we need to do something about, or does this patient have signs of oral disease that we need to act on? So the actions really are preventive interventions. There's a list of things that's down at the bottom that can be done in the primary care clinic, including application of fluoride, dietary counseling, oral hygiene training, and looking at the medication list to change medications that may be producing anticholinergic side effects. And then the actions really are carrying those out. The documentation is crucial here, because this is what we base our ability to tell what we're doing, and it builds it into the entire quality improvement process. So what we've discovered is that these are not just individual steps that you can take one at a time. They all have to be done together. And in fact, the asking and looking are really part of 2 sides of the oral health screening assessment. And what most of the care teams that we've worked with have settled on is defining a population such as patients with diabetes or pregnant women, and then doing an assessment which involves both asking and looking. And then the decision really comes down to, does this person have a risk factor or do they have oral disease, and then addressing those. So now the actions that we take, in addition to being things like fluoride in the primary care practice itself, and adjusting the medication list, can also include patient education and coaching. So and how much the primary care team can actually engage in this will depend on their structure. Fluoride can often be delivered in the primary care practice itself. We tend to think of it as a pediatric intervention, but only because it's reimbursed in pediatrics. But the reality is that caries are just as prevalent in adults as they are in children, and fluoride is just as effective in reducing those risks. So the actual signs of disease, when the intervention involves treating disease, the vast majority of these require a referral to dentistry, because we're not talking about practicing dentistry in a primary care practice. There are several things, though, that can be done for active disease. There's some evidence that chlorhexidine, if used once a week, can as an oral rinse, can reduce the infection rate in periodontal disease without dental staining. But let's talk a little bit about structured referrals, because a large piece of this really is about finding patients with oral disease that require things that only a dentist can provide. And the goal here is to make referrals to dentistry work as smoothly as they do, or at least should, for medical surgical referrals. Generally what happens currently is that if a patient needs to be seen by a dentist and is seen in a primary care practice for a complaint, they're told that they should see their dentist, or if they don't have a dentist, that they should find a dentist. But what we're really talking about here is a structured referral in which the patient is sent to a specific dentist with a specific request. Now, there's a lot of room for improvement in referrals, in medical surgical referrals as well from primary care. I think we can recognize that. And there's a lot of variation in how it's done depending on the specialty and the delivery system. So what we've done is recommend a framework for setting up referrals with dentistry that involves these 5 characteristics here, that there has to be a network of specialists that the primary care provider can then refer the patient to. They need to know their names, they need to know where they are, and they need to have a relationship with that referral network. There also needs to be specific agreements between the referring provider and the specialist, in this case the dentist, so that everyone understands what an appropriate referral is, what type of communication needs to happen, what the expectations are for when a patient will be seen, and what type of information comes back, or what to do when patients can't be contacted, who's to make the appointment, things like this. Patients need logistical support for how to get to the dentist oftentimes, and there's information that needs to be transferred back and forth to the dentist so that the dentist knows not only what question is being asked, but what other conditions the patient may have or what medications they're on that may affect their care. And then, of course, as we're trying to move towards a more coordinated referral process in the medical and surgical referrals, we also want to make absolutely sure that the primary care practices are tracking the referrals and making sure that patients arrive as they're supposed to. Now, the primary care, the oral health delivery framework itself fits very nicely into the current workflow. As we mentioned, there are things in that workflow that can be delegated or spread across the entire care team when the patient checks in. We don't expect front desk people to be asking clinical questions, but they can give the patient a list of their medications from the electronic health record, so that they can be prepared to update that with the medical assistant, and because that's an important part of looking for causes of salivary dysfunction and dry mouth. Most of the work of gathering information is done when the medical assistant rooms the patient, can ask about these oral health screening questions, inquire about dietary habits, particularly with sugar, and oral hygiene. And what we found is medical assistants can also make this process really run more smoothly for the provider by ordering and pending things, even referrals to dentistry or for coaching, for patient education, that then the provider only needs to sign. The provider's job is to review the answers to the oral health questions, to look in the mouth, sign any referrals, and then make sure that the proper information is included in the after-visit summary. Ideally, there's a health educator that can work with the patient at the end of the visit on things like oral hygiene and the dietary counseling, and of course that's when fluoride varnish can be applied. So this is how it really fits into the primary care team itself. And of course, in the age of electronic health records, every workflow is accompanied by information flow. So on the left, you can see the different roles of people who will help gather information. Again, the front desk primarily by activating the patient to think about things like their medication list. But once the information on the ask and look is entered into the computer, it then is used internally during the workflow to assist in clinical decision support. And this can be things in terms of the way that information is presented to the care team. Someone is overdue for an assessment, or the way information is presented in templates to remind the care team to look in the mouth and ask the questions and exactly what those questions are. And then, so those decisions lead to action and documentation. And on the back end, over on the right, you can see where that information then is used to write reports where we can measure process improvement and action reports to identify patients who need to be brought in for evaluation as well as outcomes. Documenting the findings is crucial because we need to make sure that this process is actually generating the type of care that we want it to. In this particular demonstration that we've been working on is largely to make sure all the wheels work and that patients receive the assessment and that risk factors and disease are being identified. So what we're looking for at a minimum is from a population perspective, what % actually have been screened with the ask and look, and what percentage of those people that are screened turn up to have a risk factor or active disease, and of those then who got the interventions, including referral to dentistry, and of those, how many referrals were completed. We're also looking at patient experience as well. So I'm going to turn it back over to Catherine at this point to talk about the white paper that was published in June.
Great. Thank you, Jeff. As Marcy noted, the Oral Health Delivery Framework was published in a white paper. If you haven't already read the paper, executive summary, I'd encourage you to download it. In addition to the framework, we go into much more detail in the paper on why primary care teams are well poised to help fight oral disease. We've also included a series of case examples from early leaders, primary care practices that have already adopted some components of the Oral Health Delivery Framework. The white paper also includes recommendations on actions stakeholders can take to support primary care practices with this new work, and I'll share a few of those in just a moment. The white paper as a whole and the Oral Health Delivery Framework specifically were developed in close partnership with our technical expert panel. And additionally, the framework has been endorsed by a broad array of primary care and oral health organizations and professional associations, which you can see listed here. We're just thrilled to have the support of Patient-Centered Primary Care Collaborative that was announced earlier this week. Additional organizations are reviewing the framework and considering offering their support as well. The response from the field has been extraordinary, and early feedback has been positive. The most common question we've received isn't why should we do this, which we feared it might be, but how can we? And is this really feasible for primary care writ large? And we think the answer is yes. Patient-centered medical homes and other advanced primary care practices have the resources in place to implement the framework in full now. Other practices that may still be developing advanced capacities, such as team-based care or referral tracking, can take an incremental approach, for example, beginning with screening and referral. The framework was specifically designed to be feasible in a typical primary care setting, meaning that it does not require additional team members or specialized equipment. And it is possible to implement in a small practice, including provider MA dyads or the teamlet type model. We acknowledge, however, that for primary care providers to deliver preventive oral health care in the long run, and certainly for patients of all ages, payment and policy changes will be necessary, most notably reimbursement for care coordination activities with dentists. In addition to payers, many other stakeholders have a role to play in helping primary care teams engage in oral health. As Jeff noted, primary care teams cannot treat dental disease. So having an adequate dental referral resource network is essential. And in the paper, we urge dentists to participate in primary care dental referral networks and to accept patients of mixed insurance status. So an important one there. We also encourage policymakers to make oral health a national research priority and to begin investing in clinical decision support that makes sense in the primary care setting, evidence-based risk assessment and screening tools, and more. Patient and family advocates, which were critical partners in championing for behavioral health integration, will be essential partners in engaging patients and families in oral health as well. And last but not least, health service educators are needed to train the next generation of primary care providers and staff, medical assistants, healthcare managers, the entire team on oral health. So we believe the oral health delivery framework is a practical and actionable model for addressing oral health prevention gaps. It's based on sound science and best thinking, but it is a conceptual model, and we want to know, not just believe, that it works. So with the support of our funders and in partnership with state primary care associations in Massachusetts, Kansas, and Oregon, we've launched an effort to field test the framework. 19 primary care practices will participate in this effort. That includes private practices, federally qualified healthcare centers with co-located dental practices, and those without any dental resources. Each site selected a pilot population, adults with diabetes, pediatrics, pregnant women, and adult well visits. We intentionally recruited for diversity, so in this group we have rural practices, suburban practices, urban, small and large. 5 different electronic health record platforms are in use among this group as well. Participating practices will receive technical support, technical assistance from Qualis Health, and in Kansas, Massachusetts, and Oregon, the state's primary care association as well. This includes goal setting, how to select a pilot population, for example, and workflow mapping and optimization to help each practice determine who on the care team is going to ask and look, and where that information will be stored, getting that streamlined, efficient process that we know is so important for sustainability. We're also providing access to clinical training resources to make sure everyone on the care team understands the oral disease process and what can be done in the primary care setting to prevent oral disease. Additional support includes the development of those referral networks, helping practices identify supportive dental partners in their community, establish those agreements Dr. Hummel referenced earlier, and troubleshoot the information transfer piece. We've asked each site to collect and report on a standard menu of measures, those Dr. Hummel shared earlier, and also to develop a plan for spread. They're all beginning with the pilot population, but we hope and expect they will expand that so that all patients served in their practice will have access to these services. In September of 2016, we'll publish an implementation guide, a toolkit reflecting our experience with field testing the framework. We expect this to include specific tools and resources that have been useful to the field testing sites. For example, sample workflows, referral agreements, and so forth. It'll also include impact data and case examples. That toolkit will be adopted into the Safety Net Medical Home Initiative Resource Library, joining a suite of materials published last year on behavioral health integration. So we are just in the very beginning phase of our field testing work, but we've already learned quite a lot. And I'll turn this back now to Dr. Hummel to summarize a few of our early lessons.
Thank you, Catherine. So I think the main thing we've learned is that this workflow and the oral health delivery framework does work. And it, as Catherine says, it works across a range of primary care practice settings, in addition to safety net medical homes, individual private practices. We have rural sites. The thing that's most striking is that the care teams really identify with this, and patients do as well. It's very clear to folks on the front lines that dental needs, that dental care is an unmet need. So, and the other thing we've learned is that the number of referrals that come out of this process are not huge. We kind of wonder why that is. I think that it's like any referral, it's a shared decision that patients make, but it does not overwhelm the dental resources in the referral network. We do know that the patients really appreciate the attention to oral health that is given, and they do respond to the teaching and the coaching that the practices provide. Primary care physicians really understand the value proposition that this is. This is seen as a complaint that patients can come in with that they really don't have an answer for, and that's an uncomfortable position for primary care providers to be in. We don't like saying, I can't help you, you have to go somewhere else. The chronic disease link is very clear. It's becoming increasingly aware of, providers across the spectrum are becoming aware of this. I think the behavioral health integration as a precedent has been important, because what it means is that a provider now is not afraid to open a can of worms and ask about things that he or she does not have an answer for. In behavioral health, to really inquire into depression or some of the social issues in patients' lives without having someone to then refer the patient to help with would be a reason to sort of tiptoe around the topic. And oral health is very similar to that. Being able to say, look, I know who to send you to, and I know something that we can do about this, makes it much, much easier to address the problem. I think the basic thing in why this resonates with primary care is that all of the aspects that we've talked about are really core primary care competencies. This is both caries and periodontal are chronic infectious diseases. The anatomy and the pathophysiology of the mouth are all things that are very familiar. Primary care physicians are not used to thinking about the teeth and the gums, and have sort of habitually just gone around them and looked past them. But once they start to understand how it all works, it's the same. It's the same anatomy and physiology. Prevention is where primary care lives, and structured referrals are how we do business. So this really fits very nicely into the way primary care is already structured. Now, having said that, we have run into a number of challenges, and I think the biggest ones are simply the competing priorities. There is a tremendous amount of change going on in primary care right now, including things like behavioral health integration and patient-centered medical home certification and things like that. There's also all of the changes that are built around value-based reimbursement really affect primary care practices and have placed them under stress. There's just this week the ICD-10 conversion that has displaced a lot of people's energy to take on a new project. So what the net effect is we're in an environment that really is experiencing change fatigue. At the bottom of this, though, kind of the core issue, as Catherine said, is reimbursement. Because what primary care providers are faced with is a situation in which reimbursement reform has really lagged behind the vision of value-based care and value-based reimbursement. What that means is, in order to do chronic illness care, and I would include oral health in that because this is a chronic disease, the only way to do that, and we're having our outcomes measured for quality almost entirely for chronic illnesses, so oral health will be no different than that. In order to do that, you have to have a complex team to share the care with, and yet we're stuck in a situation where the reimbursement is primarily for only for things that the primary care physician does, which means that the primary care physician has to run faster and in order to produce enough revenue to employ the people who are actually doing the work for chronic illness care, and in this case for oral health. The referral process for dentistry is new, and it oftentimes requires figuring something out in real time during the visit. And what we find is a lot of times the primary care provider will say, I don't have time to figure this out right now, and that may be one of the barriers to referrals. We're also dealing with just the environment of health information technology, which is a rigid technology, and it's very difficult to insert it into the fluid culture of primary care office visits. And that in turn then means that if we're trying to introduce something new into that, such as oral health, there are barriers simply in terms of, can we modify the user interface to take new information? Are there organizational barriers where they've locked down changes in the EHR simply to standardize workflows? We've also found that medical dental information exchange is difficult. Even if the referrals go, getting the clinical information to the dentist and back from the dentist to the primary care provider is very difficult. The EHRs and the electronic dental records don't talk to each other very well, and products that are integrated into large EHRs are just being developed and marketed now. So the conversion or the adoption of those into a functional information exchange is lagging behind our efforts, certainly. What we found is, in terms of strategies that work, is to start small. Start with a single subpopulation, such as diabetes or pregnant women or children. Work with one care team to get the bugs out of the workflow and make sure it works. And then oftentimes the practices cannot do the whole spectrum of interventions that we've talked about. And if they simply limit it to identifying disease and referring and then tracking those referrals, we consider that a success. It's a toe in the door. Likewise, if we can start to identify patients with caries risk and treat those with fluoride and patient education, we'll start there, and we can move on to the full spectrum after that. We've really built our workflow optimization efforts around limiting the impact on the provider, because we see that as the bottleneck. The providers are the ones responsible for everything, and the more we can unload them and simply put them in a position of making clinical decisions and doing shared decision making with patients, the better. We also have to understand and work within the limits of each health information system installation. There may be things that a particular clinic simply cannot do with their electronic health record, and we're better off understanding those limits and working within them than trying to convince them to change. So I'm going to turn it back over to Catherine to talk about our next steps.
Thank you. Our priority this fall is to continue dissemination efforts for the white paper, the Oral Health Delivery Framework. If you have questions about the content, ideas on organizations that might be interested in this, please contact us. Our first cohort of field testing sites will complete their pilots in June. We'll have some early data then to share. The remainder will be complete by the end of 2016. We're on target to publish the implementation guide I referenced earlier in September of 2016, so just about a year from now, and hope that will provide a useful resource to all of you. We're also looking at other opportunities to ensure that oral health is reflected in patient-centered medical home model of care programs and in other primary care improvement efforts. We'd welcome your ideas on that today. And with that, I will turn it back to Amy to moderate our Q&A session. Amy?
Fantastic. Well, thanks to both of you for an incredible presentation. I think you laid this out in a way that really demonstrates how doable this can be in primary care, but also really acknowledges some of those challenges. So speaking of challenges, maybe you can imagine, I'm guessing you hear about this a lot, you talked a little bit about the payment, and again, acknowledge that there's still some improvements that need to be made there. But let's get down to brass tacks. What is currently being paid for as it relates to this framework in primary care? And are there differences between Medicare, Medicaid, private health plans, and kind of where do you see that headed?
Sure. Let's begin with what's paid for now. I would say there is generally good opportunities for reimbursement for children. Most payers, Medicaid programs, provide coverage for fluoride varnish for children. The frequency and age limits vary state by state, but again, good coverage there. That often includes additional reimbursement opportunities for family education and for the risk assessment and the risk assessment and screening component as well. So I'd encourage you to look within your state what's an opportunity there. The U.S. Preventive Services Task Force recommended fluoride varnish for young kids, and that led to private payers adding coverage for that service as well. So I think the takeaway message is there's good opportunities for reimbursement for children. For adults, the picture's a little bit more complex. There are, and if folks are interested, I'll refer you to the white paper. We go into more detail on this. Some payers that provide reimbursement opportunities for care for adults, but again, that's much more limited. It's certainly something we hope and expect will change in the future, and I will say a trigger for that is, as we shared earlier, some of the new evidence coming out that's linking reductions in cost of care for medical care for patients with chronic disease when they have well-controlled oral disease improvements in oral health.
And I would just add that if there were any changes that could be made in the reimbursement that would really move this along, I think the biggest one is that patients don't have dental insurance, and that so that providers are reluctant to send patients to a dentist when they can't pay for it, or they're going to be offered things that are outside of their ability to pay. Within the primary care practice itself, I don't think providers expect to be able to bill for looking in the mouth any more than they expect to be able to bill for looking in the ears. But what we do, I think what would really help is if procedures, particularly when there's even a minor cost associated with things like with fluoride varnish, if that were covered for adults, I think it would make it a much more, it would make sense to the primary care providers to screen for caries and then simply have the costs of providing fluoride varnish to adults covered as well. But what's really needed, of course, is full reform in which value-based reimbursement is the majority of the reimbursement that providers get.
Right. So primary care teams are given that flexibility to address all of the patient's needs in lots of different ways. So kind of talking along those lines, Are you hearing from anyone, or are you aware of any of the specifics as it relates to who in the practice can do some of these things? I mean, Dr. Hummel, you kind of talked to this a little bit by saying we're still in this old model where only the doctor is paid to do most of the care. But as people are looking to expand care teams and expand roles of medical assistants, what are you seeing in the practices as it relates to any of those procedures like fluoride varnish? Are there constraints around those?
Well, certainly fluoride varnish can be administered by a medical assistant, but it's finding time to do that. That's the challenge. So if you have a teamlet where there's simply a provider and a medical assistant who's not only rooming patients, answering the phones, and expected to do any procedures that may need to be done during or after the office visit, that becomes the bottleneck. So it's a matter of will there be enough reimbursement for the care team to be expanded beyond that teamlet. I think that's a consideration there. But in terms of we see a spectrum of different approaches to delegation of tasks, and certainly we've encountered a number of practices that are very willing to let the medical assistants look in the mouth and make an initial observation as to whether they think there may be, the patient may have caries or periodontal disease. I mean, from a dentist's perspective, they're the only ones that are really capable of making that diagnosis. So we're not expecting the medical assistants or the providers, the primary care providers themselves, to make a diagnosis of dental disease. But what we're asking them to do is look for the signs. And then if the medical assistants are the ones looking in the mouth, they can certainly make a note of that in the primary care provider's chart, and then the provider, as with everything else, will review that and look over the entire situation before making the decision. So I think there's an evolution towards complex care teams, and really what's limiting us now is the ability to support that financially.
Absolutely. So let's go look at the other spectrum. A practice that has said, you know, this is such a concern for the population I'm caring for, I'm going to bring a dental hygienist onto my team. Are you aware of any primary care practices that have integrated dental hygienists into their care team?
We certainly are. There are a number of practices, primarily FQHCs or other community health centers, that do have resources to bring on a dental hygienist. The framework that we've designed does not require that. So the actions included in the oral health delivery framework are possible to provide with a typical primary care team. Now, if you have that added resource of a hygienist, there is more that you can do. We think it's very important if a primary care practice is going to add a hygienist, that hygienist becomes part of the primary care team, the core primary care team. So they're huddling with the team. They're included in the team's QI meetings. They are a working member of that care team. That's really important for looking at comprehensive and whole person care. But there are models of that out there, and if folks are interested, we can point you to them.
Fantastic.
I would also say in our field test group, we have, I think, 2 now that have hygienists, so we'll be able to share a little bit more as we're going through that work, what that looks like in terms of a staffing model. We've also seen primary care teams use other sort of non-traditional members of the team on oral health, promotoras, community health workers, AmeriCorps volunteers, all sorts of different folks that may be available to them, particularly important for looking at that patient engagement, what Jeff mentioned earlier, the oral health counseling, and hygiene training. So think broadly on who you have on your team and who can help with this work.
That's a great point. Talking about kind of getting this more instituted into part of what we were talking about in primary care, what's going on in the medical schools and residency programs? Are you familiar with some of the schools that have started to really integrate this framework into their curriculum?
I'm aware that a number of universities are doing interdisciplinary training with dental students and medical students. So they're taking classes together, and there is an effort to integrate. Certainly the University of Washington, which I'm most familiar with, is starting to, they've actually redone the curriculum in the dental school so it's synchronized with the teaching techniques and some of the content of the medical school. So I think that is something which the educational community is starting to respond to. I think, as always, there's an opportunity to increase the amount of communication and the mutual respect across the two professions. Ultimately, what you want to do is for there not to be the divide that I think historically has been there, but for the two professions to really see each other as colleagues. For which there's methods of communication, so that the thing that we found that's of greatest value for the practicing dentists is not only just the stream of patients, but also having a person that they can call up and ask questions about, because dentists run into a lot of medical problems, blood pressure, patients on blood thinners, or things that complications that may involve a medical consult, and having those personal relationships from the time that the training occurs in dental school and medical school, I think is probably the best way to build those.
There's also been great traction for nursing programs, for physician assistant programs, and also for some midwifery programs. So true interprofessional interest there. If folks are interested in learning more about that, HRSA published a paper about a year and a half ago on interprofessional oral health care. It's called the IPOC paper, and they laid out a number of recommendations for engaging the health professions very broadly in this topic.
Yeah, and I would also encourage all of our participants today to go on the PCPCC website. We've been talking a lot about interprofessional training and different aspects to those curriculum, and we've got a great database online. So if you want to take a look there and see what are the various professions and aspects to the program that are being integrated all around the country, I think you might find some good information there. But Dr. Hummel, you brought up a good lead-in to a couple questions that have come through regarding, you know, what has been the organized dental community's response to this, and how are they feeling about having more collegial, as you were talking about, more close relationship with primary care?
Well, dentists, like physicians, are not I mean, they're a heterogeneous bunch, and you're going to find a spectrum of different opinions that you know, partly are just personality and partly are age-related, generational. So I mean, there are a lot of stereotypes out there which are not entirely incorrect. It is sometimes a challenge to find dentists, particularly who will see patients who are on Medicaid or who do not have insurance. But that's not a monolithic stance, certainly. What we've found, there's a couple of resources that practices have for developing referral relationships with the dental community. One is if a dentist is not completely full and has some capacity, that it's a pretty straightforward argument that a stream of patients with a mixed type of insurance or a mixture of different insurances is better than an empty chair. There are always sliding scales and ways of working out payment for patients who do not have insurance. So that's one of the barriers. We also find, and I think this probably depends on the state, but the reimbursement for Medicaid, when dental care is covered by Medicaid in many states, is sufficient that the dental clinics in federally qualified health centers are not losing money seeing patients. They're able to make that work financially, and they're actually expanding capacity. Now, they may not be, you know, the profitability obviously is much lower with that population just doing general dentistry than it would be with a very high-end dental practice. But the point is, there are places in the dental community that are willing to take new patients, and that they find that relationship with the medical practice to be of enough additional value that this is an arrangement that they're very willing to pursue. And we've been quite successful here in Washington State, particularly working with the Washington State Dental Service Foundation in helping us identify those practices. That I think, a direction that we'll be able to continue to find capacity in.
That's great to hear. Okay, so I want to wrap it up with a kind of two-parter question. So you've generated a lot of great interest from our participants, and they want to go do this. So first part of the question is, where would you suggest they go for materials and resources that primary care teams can give to their patients about oral hygiene, both for children and adults? And then the second part is, hey, I'm really interested in really integrating this framework into my practice. I'm not part of your pilot program that's testing this out. How can I get some resources, or are there resources that exist for practice coaches or people on the care team who can really start to integrate this in a way and through quality improvement efforts?
Sure. So great questions there. For primary care practices that are interested in learning more about delivering preventive oral health services and looking at resources available that they can use in their practice, the Smiles for Life curriculum is a great resource. That's a free training curriculum online. We can send the website out later. There's also a host of patient education pamphlets, education materials that have been translated into a variety of languages. They exist kind of all over, and we'd be happy to share those with folks if they're interested. Some are available through departments of health. The American Academy of Pediatrics has some terrific resources, and again, happy to share some direct links after that. There are fewer resources available for adults, but there are certainly some for adult patients with diabetes. The Washington Dental Service Foundation has some nice ones, and many others. So again, we can follow up some specific links for folks that are looking for patient-facing education resources and clinical content, clinical training resources as well. In terms of other tools that will be coming out from Qualis, again, those won't be available until 2016, but they are on the horizon and in the works. If there are primary care practices that are interested in taking the next step, you'd be welcome to contact us after this session to learn a little bit more, and we can go from there.
Fantastic. Well, we are out of time, and I apologize we were not able to get through all those questions, but I'll certainly send them over to our presenters, and they can do some targeted follow-up afterwards. And again, please go to the Qualis website. Lots of great resources and links there. So thanks again for everyone for attending today's national briefing for the Patient-Centered Primary Care Collaborative, and a special thanks to Dr. Hummel and Catherine for this fantastic presentation. Thanks, everyone.
Yep. Thanks so much.